We're live. Hi guys, welcome to the final review. We are gonna go fairly quickly to try to get through all of it. I'm gonna not look at my head. So first question, or I guess it won't necessarily be first based on your shuffle, but you are gonna have the 15 suffixes. So make sure you have a clear understanding of which drug classes those belong to. So like prazole, proton pump inhibitor, prills, ACE inhibitors, that kind of thing. Just make sure that you understand those, that you're able to attach them. Biggest struggles that I see with those particular drugs is that people confuse those drugs that have the same or similar endings. So your dipines, your azines, your zine, dine or dean, those tend to be easily confused. This is worth 15 points. If you miss 3, you get 12 of your 15 points. So I will manually grade these, do the best you can on that, but expect to see that match somewhere in there. If you use a drug class twice, you are doing so in vain. Okay, so there are 15 suffixes and there are 15 drug classes. So before you move on from this question, make sure that you have only used each drug class one time. Your patients who are taking aspirin, long-term use of aspirin in coronary artery disease, blood clotting disorders, that kind of thing, comes with an adverse effect of bleeding, be that upper GI, lower GI. It more often comes in the form of upper, and you're going to have dark tarry stools from it. So be mindful of that as an adverse effect. Know what your parasympathetic does. So your parasympathetic, what it does to your brain, your eyes, your secretions, your airway, heart, GI, GU, your peripheral vascular resistance. I want you to know it for your sympathetic responses as well. Be able to tell me what would happen if I turned up or down that system based on if I'm using cholinergic drugs, adrenergic drugs, that kind of thing. So know what's normal and know what would be abnormal. So your blood glucose is often elevated in a sympathetic response. So normal blood glucose is 60 to 100 milligrams per deciliter. You would expect it to be increased in a sympathetic response. We use epinephrine for anaphylactic reactions, and our therapeutic effect or our goal is to have a bronchospasm terminate. Okay, so we want that airway back. The therapeutic is different from the drug is working. Therapeutic means I have achieved my end result. The drug is working means that I have signs and symptoms that the drug is active. Phenylephrine, so this is a sympathetic drug. This is used for nasal decongestion, or for nasal congestion, I should say, is a decongestion. It is a local spray. You inhale it. And it vasoconstricts your nasal passages. And when you constrict those vessels, you actually reduce the inflammatory response. And that allows you to breathe easier. You get decongestion from that response. Prazosin, so this is an antihypertensive medication. It's a second-line drug. It is an alpha-1 adrenergic blocker. So we're worried about potentially having some adverse effects related to the start of antihypertensives. So syncope, know your cardiac rules, and just know when to hold a med and when to call. Propranolol, so beta non-specific, it's a blocker. Adverse effects, contraindications here. So I'm worried about my airway with this drug. So if I've got patients that have some sort of constrictive airway disease, I want to be mindful not to administer this medication to them. I also want to be careful with my patients who are on beta 1 specific blockers, because an overdose of that, be it intentional or unintentional, can cause the drug to become non-specific, and you'll see those same kind of reactions as propranolol or a non-specific beta blocker. Bethanacol. So I give bethanacol to my patients who are having urinary retention. So I just delivered a baby, or I just came out of anesthesia. This is something we traditionally give to patients who are hospitalized. We usually know you can't pee, you can't go home until you pee. So we want to be aware of what the adverse effects of bethanacol are. So bethanacol is a cholinergic agonist. It comes with a parasympathetic type response. It is going to cause increased secretions. It's going to dilate your pupils. It's going to cause low blood pressure due to a decrease in cardiac output and a decrease in rate. Some of these things might not be that big of a deal. But hypotension, orthostatics, that kind of thing, that's going to be a big deal. So if you're looking at a priority question, make sure that you understand how to choose what things are side effects and what things are big adverse effects. Pyridostigmine, we use this to help improve our myasthenia gravis patients' muscle strength. Understand that myasthenia gravis patients have periods of weakness throughout the day when their myasthenia gravis drug is wearing off. So their drug is wearing off, they've just taken another dose. These are valleys, I like to call them, and these are spaces in the day where you need to not have a lot going on. Don't eat your meals. Make sure that you take your meds evenly spaced throughout the day to maintain muscle strength. I take my meds at night and I take them in the morning before I go to the operating room, or I'm going to lose muscle strength. The muscle strength goes in your head and neck first. It definitely keeps going, but for us, one of our priorities, especially when it becomes time to administer medications to these patients, is that we do a little mini swallow on them. So a little cup of water, a couple of sips out of there, and if you start to hack, I know we have a problem, and we need to talk about a different type of administration of the drug because your swallow is compromised. Make sure your patients go to the doctor. Make sure that they understand how to manage their medications. So if your patient takes a medication and as soon as it becomes effective, or subsequently becomes, your patient subsequently becomes weak, then you want to make sure that you understand that that is going to be some type of cholinergic crisis. So I have the drug on board, I take another dose, as soon as it kicks in, I am weak, right? So cholinergic crisis. If I take a dose and an hour goes by, 2 hours goes by, and I start to become progressively weak, that means that I'm developing a tolerance to my medication and I need a higher dose of it. So tolerance, drug resistance, all the same thing, okay? So if I go into the hospital and I have weakness and I can't describe really, or the healthcare providers don't know or don't have reasons to think it's absolutely cholinergic crisis or myasthenia gravis crisis, then I need to test my patient with adrophonium or the tensilon test in order to determine how I should be treating them. I use succinylcholine to decrease muscle movement in my patients who are getting short-term procedures like electric convulsive therapy. In that instance, I'm not using enough of the drug for my patient to lose their airway. But if I go just a little more than I should for that type of procedure, I am absolutely at risk of losing my airway. So my patients need to have the right doses. If I'm looking to intubate and it's appropriate to use acetylcholine, I need to understand a couple of things. So if my patient has ever had malignant hyperthermia in the past, or if they've got a family history, so this muscle rigidity, high fever, then I've got malignant hyperthermia and I need to manage that. If my patient has a history of, or currently has, I should say, or has some sort of, currently has hyperkalemia from some sort of comorbidity, or if they have had a big injury, trying to throw things on the ground, if they've had a big injury, trauma, burn, that kind of thing, then we want to be mindful of them as well, because they will have hyperkalemia. So acute respiratory distress syndrome, or ARDS. So this is a disease process that is often on your way to respiratory failure. It's a precursor to it. We like to intubate these folks. We want to either give you a rest or give you support depending on how long you have been struggling. And we will often use some of the cure drugs, is the core, CUR. So these drugs are non-depolarizing neuromuscular blockers. They're longer acting. They've got a half-life of generally about 60 to 80 minutes. And we want to give this drug to our patients to suppress their respiratory effort. We do not want them to fight oral endotracheal intubation, and we do not want them to buck the vent or fight the vent. So if my patient is able to overbreathe the vent or is resistant, I need to be mindful of, are they sedated enough? Do I have enough of the pancuronium on board? Usually it's not enough, but goal of treatment is to cause that paralysis. So acetazolamide, this is a diuretic drug. We use this for our glaucoma patients. It's usually a last line drug. We don't love it because it often causes metabolic acidosis. Furosemide, Lasix. So we use this drug for our patients who have heart failure. We need to move a lot of fluids off. So you're wanting to know a lot about your cardiac rules here, what's normal, what's not. Your patient needs to get up slowly, they need to weigh themselves daily, they need no more than 2 pounds a day, 5 pounds a week. Your patients who are taking Lasix are going to dump potassium. So sodium, chloride, potassium, water, it's all going to go. So oftentimes what you may need to do is teach your patient to eat a whole foods diet to include foods high in potassium to replace what is being lost with regular use of Lasix. We also take our Lasix in the morning. If I've got 1 dose a day, I take it in the morning. If I've got 2 doses a day, I take 1 in the morning and 1 as early in the afternoon as I can, so that way I'm not up all night going to the bathroom. Hydrochlorothiazide, so this is the first drug of choice for our patients who have hypertension. If I have a hypertensive patient who's also in chronic kidney failure, I am worried about that patient becoming fluid overloaded. So maybe I have some chronic renal failure and we're trying to use hydrochlorothiazide, which would just be weird. But what we are really looking for is, do we have fluid overload in this patient? Maybe we've got kidney injury that turns into like a more progressive disease, but you're looking for that fluid to back up. So if you've got crackles, you want to just make sure that you're doing a good job with your lung assessment. Mannitol, so we use mannitol in increased interocular pressures, increased cranial pressures. You were standing on top of this patient when you were given this drug IV. They are going to have a lot of profound shifts in fluids and electrolytes. You have your eyes on their vitals, and you're doing Q15 neurochecks. So make sure you have a good handle on your blood pressure because they can tank really quickly, and make sure you assess their level of consciousness. Your patients who have renal failure are going to have an elevated potassium. So your patients who have elevated potassium that need a diuretic are going to need to use a potassium sparing diuretic. So spironolactone, albactone is going to be your prototype drug for that. D5W, dextrose 5%. I like to use this to dilute IV drugs with. I don't use it to fix hypoglycemia. I use D50. I don't consider this drug to be a good source of calories. It's got 170 calories in a bag. So calories per milliliter, it's just not significant enough to feed your patient. You'd have to be dumping, a liter in them to get 170 calories in them in an hour. Okay, so if you tried to get that in a day, it's just a lot of fluid per hour. You're going to fluid overload them, so not a great choice. Go higher. Go to a D10, go to a D20 if you need to help with some sort of replacement. Some sort of replacement in particular you might want to think about is if your TPN bag runs out. You want to at least D10, if not D20, depending upon your facility's protocol. So dextran 40, not to replace sugar at all. This is a fluid volume expander. We want to use this in patients who've lost a lot of volume. If you have a hemorrhage patient, you want to fix the hemorrhage before you use dextran 40. Dextran 40 is also used to help people to help prevent people from clotting when they are at an increased propensity to do so. So make sure that you're not worried about your patient continuing to bleed, but great drug, gives you 12 hours of double fluid volume. I want to be really, really mindful of my cardiac status with this drug, and I want to make sure that my patient doesn't become fluid overloaded. IV MAG, I use this for my pregnant patients. It causes central nervous system depression, and with that depression, I have less muscular contraction, so I'm less likely to contract and expel a baby. I'm also less likely to seize, and we use it for both preterm labor and for preeclampsia and eclampsia because of its ability to depress the central nervous system. Know how to push potassium, or maybe not push potassium, okay? But 10 milliequivalents an hour through a peripheral, 20 through a central line. If I have an oral liquid, I dilute it. It's gross. If I have a tablet, I don't break that tablet. I don't chew that tablet. I just go ahead and swallow it. Know how to read a blood gas. Know what sodium bicarb is used to treat. So we use sodium bicarb for metabolic acidosis. We use ammonium. It's rare. It's very, very rare. Ammonium chloride for metabolic alkalosis. Did I say that right? Acidosis for sodium bicarb, alkalosis, ammonium chloride. Okay. And then if your patient is being fluid resuscitated, the goal of our treatment is to expand their plasma volume, and in doing so, we should see a decrease in their heart rate and an increase in their blood pressure. Albuterol. So know how to administer albuterol. So I prime the pump, I shake it before each use. I don't have to prime it every time, just the first time, or if there's been an extensive period between the last use. I usually say over 2 weeks. Most of our asthmatic patients don't have trouble with this. Usually you can just spray or depress the canister and squirt out and then use the next one if it's been a super long time. But you put it up to your lips, you inhale while you depress the canister, you hold the drug in for 10 seconds, you then exhale. If you need an additional spray or puff, then you use it, and then you rinse your mouth out after all of your oral inhaled medications for airway diseases. Okay. So if I'm taking one of these drugs, if I'm taking some of the older drugs, so Montelukast is a mast cell stabilizer. If I'm taking it, if I'm taking Cromolyn, albuterol, theophylline, I want to just know that my therapeutic intent or therapeutic effect is to be able to breathe. I just want to be able to breathe easier. Okay. If I have a patient who wants theophylline, they only really get it if it's an emergency or if they have been on it for a long time. So what I want to do is just let them know that we try not to use the drug because of adverse effects, that we have much safer drugs that don't require monitoring on a regular basis, and that albuterol would be the best drug of choice if they were bringing in their child or if they have a new diagnosis themselves. So thick, nasty, tenacious secretions, we like to use mucolytics, acetylcysteine, mucomist for this particular patient population. We are hoping to break down the DNA of the mucus and make it less sticky. Okay. Benadryl versus Allegra. So diphenhydramine versus fexofenadine. So diphenhydramine is a first generation histamine 1 blocker. And what it does is it competitively binds to the histamine receptor, so that way the histamine from whatever immune response you're having can't bind to the receptor and keep causing more inflammation. But it crosses the CNS barrier, and with that it causes sedation. That might be great if you're like going to bed, or if you just want to go to bed and it's 2 o'clock in the afternoon because you've had enough. But for most of us, it's not an effective way to live our life with allergies. And so we want a second generation drug that doesn't have that ability to cross the CNS barrier or the blood-brain barrier, and therefore doesn't cause CNS depression. Okay. Pseudoephedrine, so this is an oral drug we take. This drug, you need to talk to your patients who are hypertensive. When they go home after they've been diagnosed with hypertension, they need to be advised not to self-medicate their allergies, but to call the clinic and ask for assistance. We want to make sure that we let them know about that when they come in for their spring visits and their late summer or early fall visits, because those are where people start to struggle with allergies. Okay, so a little reminder will go a long way. If I start treating my patient for primary hypertension or idiopathic, like I don't know what caused it. I feel like this isn't really a thing, but I feel like we know what caused it. Do you guys feel like we know what caused it?
Yeah.
It's usually a lifelong therapy. Some people do really great. They make the lifestyle modifications and they are able to make the changes and get off the drugs. For the most part, they're not. Okay, so for the most part, it's going to be lifelong treatment for these folks. Your patients who have coronary artery disease, they will traditionally have elevated lipids. So you are going to see decreased HDL. So HDL is the good guy, right? It's your garbage collector. So there's not going to be enough of them. You're going to have high LDL and high triglycerides. So grapefruit juice is bad. You don't want to use grapefruit juice in your benzodiazepines, calcium channel blockers, statins, just to name a couple, okay? So your cholesterol patients, they need to be taught lifestyle factors, and they need to understand that we didn't get to super high cholesterol hyperlipidemia overnight. Same thing with your hypertension patients. We're not going to fix this in a month. Oftentimes, the modifications, especially short term, are not enough to combat the long-term problem. So diet and exercise alone may not be enough. We'll continue to monitor you. When we get to a point where you're safe and we're no longer worried about cardiovascular disease, we will go ahead and talk about discontinuing the medication. Ezetimibe, so this is a drug that we use for hypercholesterolemia as well. And it is going to come with lifestyle modifications, just like all the rest of them. So we want to be careful to mention to our patients that they need to decrease the overall cholesterol in their diets when they're on these medications. And lots of times that doesn't mean anything to our patients. And so we need to talk about meats and fats that become solid at room temperature, okay? So pull some of your nutrition forward for them. Niacin. So if I'm taking niacin, I'm going to end up with a couple of adverse effects. I'm going to have an upset stomach or GI upset, and I'm going to have some flushing. So I want to make sure that I take an aspirin about 30 minutes before I take my niacin to help with the flushing. The GI upset you get to keep, unfortunately.
So lucky.
Hypertensive crisis. So I treat my hypertensive crisis patients by one, getting their blood pressure down so they don't stroke. I use nitroprusside to do that, nitropress. And I figure out what is wrong with them, okay? Get rid of whatever is stimulating that hypertensive response. Know about antihypertensives, which ones are used to treat hypertension, and know how to start your patients on them. So start low, go slow, do it at night, follow up with your patient. When it's safe to transition them over to the day, you transition them to the day, because they are going to have more episodes of hypertension during the day, or more consistent hypertension during the day, and therefore they need to take their meds during those hours. Metoprolol, so beta 1 specific. My betas, if in general, in normal life, when your beta 1s are stimulated by norepinephrine, you get an increase in your heart rate, you get an increase in cardiac output, you get an increase in release of renin, which causes further hypertension through the actions of angiotensin II and aldosterone stimulation, vasoconstriction. So I want to block these in my hypertensive patients or in my patients who are struggling with reflex tachycardia. So make sure that you understand your cardiac rules for when you can give them. Understand that there are some contraindications. So if I've got a super low heart rate, if I've got blocks, if I've got moderate or above heart failure, I don't want to make those things worse. Nifedipine, calcium channel blockers. Know how to administer your meds. So before you give a med that's going to slow down heart rate, slow down contractility, and slow down conduction, make sure you have a really good handle on whether or not it's safe to do that. So what's my heart rate? What's my blood pressure? Do my cardiac rules make sense? Lisinopril, so your ACE inhibitors, we use these because we want to decrease our blood pressure. They're cardioprotective, they prevent cardiac remodeling. These things are really, really great. They should be one of the first line drugs used in hypertension. Angiotensin receptor blockers are only used when your patient has failed an ACE inhibitor. And an angiotensin II blocker does just that. It blocks the angiotensin II receptor. Okay, and this becomes kind of muddy because the angiotensin II receptor is actually called an AT1 receptor. So don't get confused with this. ACE inhibitors don't block that receptor. They inhibit the ACE product itself, so you don't have any converting enzyme to convert it. So make sure that you don't stumble on that. It blocks a receptor. That's what your sartan drugs do, or your angiotensin receptor blockers. Your angiotensin converting enzyme inhibitors are going to prevent angiotensin 1 from becoming angiotensin 2, to be able to differentiate those. It's often very confused. So you need a transplant. You end up on long-term transplant meds. You are looking at an increased rate of having cancer. You have myocardial infarction, and you need to go home with a whole new bag of meds. You need to teach your patient the cardiac rules and be able to apply them to this particular set of questions. Know how to administer nitro. So if I go home, I've had an MI, then I want to make sure that I keep my bottle, my brownish bottle, with my meds in it. I don't open it till I need it. I don't expose it to heat or light or extreme variations of temperature. I sit down if I begin to have chest pain. I take a tablet. It must sting or bite under my tongue. And I wait 5 minutes. If I still have chest pain, I need to call 911 before I take the second nitro. It's kind of a simultaneous thing, but our algorithms at this point say you need to call. Then take the next tab. Okay. Nitroglycerin causes reflex tachycardia. Some of the drugs that we talked about, especially in the beginning of the chapters, are going to cause reflex tachycardia. And if we have patients who are on a drug regularly, or maybe they're just in the hospital and we are treating them and they are tacking away on us after we've given nitro, or if we've got a nitro drip running, what we can do is we can use a beta blocker. So your digoxin patients are going to have some adverse effects. Your adverse effects look a lot like dig toxicity. So if your patient ends up with GI upset, then they're having adverse effects, right? So you want to get them in as mild as it may seem, but because dig toxicity looks like their standard adverse effects of GI toxicity with dig, you just don't want to risk it. So any GI upset, it's adverse effect, have them come in. You are using lidocaine on your patients. This used to be a really popular thing for cardiac conduction. It used to be an antidysrhythmic we used a lot. We don't use it a ton anymore, but it will help prevent dysrhythmias after CPR has failed. Your body oftentimes will need assistance fighting cancer, so I will use an immunostimulant for that. Interferon belongs to that particular class, so know your drugs in your interferon class, or I'm sorry, in your immunostimulant classes. Bone marrow suppression. So bone marrow suppression causes a decrease in your platelets, red blood cells, white blood cells. So if you have bone marrow suppression, you are at risk for infection and risk for bleeding and risk for generalized anemia. Okay, so but be that anemia just as itself or aplastic anemia, just treat that as bone marrow suppression. Okay, basiliximab. So we use this for transplant rejection. We use it a couple hours before you get your transplant. We use it again about 4 hours after you get your transplant. We're trying to get on top of your body's immune response to that foreign tissue before it gets started. In transplant of any tissue, it is a lot easier to stay out of it than it is to try to come back from behind. Okay. So art therapy. This really throws everybody. I'm really surprised by this. So antiretroviral therapy. This is what we use in our HIV patient population, our AIDS patients. This is a combination drug therapy of antiretrovirals. 2, 3, 4 drugs at a time. It's expensive. It's unpleasant. It causes bone marrow suppression. So know the signs and symptoms of bone marrow suppression. Know how to apply eye ointment, eye drops. Know how to apply ear drops. Doxorubicin, this stuff's bad for your heart, causes cardiomyopathy. I want to know how much of it you've ever gotten before I give you any of it in the clinic. So make sure you have a real good handle on what their lifetime dosing is. Make sure you've got the cardiologist involved. Make sure you've got a baseline EKG before you administer the drug. Methotrexate. We are looking for how you manage bone marrow suppression here. So if your patient is sick all of the time, or if your patient is bruising or bleeding from their gums, or they're just really, really tired and can't seem to do their basic ADLs, we want to get a CBC, get some labs, and figure out what's going on with them. We may need to stop the medications. Tamoxifen, we use it in breast cancer. It causes menopausal hormonal type responses in both men and women. So hot flashes, fluid retention. In women, you may see changes in vaginal discharge. Take your contacts out before you put your eye drops in. Know what to expect for your patients who are coming in to your emergency department who have ingested drugs. So any of your uppers or your sympathetic stimulants, so cocaine, methamphetamines, crack, I don't know, there's a list. You're going to expect them to have dilated pupils. Your patients who are overdosing on heroin or OxyContin, some other type of opioid, they're going to have a pinpoint pupil. So latanoprost. So this is the really cool drug that helps in glaucoma, and it will cause you to have more of the fluid flow out of the eye, and that's how it reduces pressure. It changes the color of your eye, so it can add pigmentation to the iris and around the skin of your eyes. It can also cause your eyelashes to become thicker and darker. Okay, so know what's normal. Know that you need to teach those things to your patient. You shouldn't expect your patients to have a systemic response to eye drops. If you are seeing that in your patient, they are either using way too much or they are dumping these drugs straight into that nasal lacrimal duct. Okay, so make sure that you have your patients do teach back before they leave so we know they're getting their meds in there correctly. Pilocarpine, so this drug is going to be a cholinergic agonist. I am again looking for you to tell me what you expect to occur from a parasympathetic response. Your patient is going to come in for treatment for glaucoma and open angle glaucoma. You need to have a good understanding of the longevity of treatment for open angle glaucoma. So you don't just get glaucoma and it goes away unless it's closed angle, and that's a medical emergency. We go in and we fix it. But in open angle glaucoma,
This is a lifelong disease process, and your patient needs to get ready to take their medications as prescribed daily for the rest of their lives. Amoxicillin, so we're looking at ear infections now. So if you have an inner ear infection and you have a patient who's having adverse effects, know which adverse effects are normal and which adverse effects merit a phone call to the 911 provider. Know your antidote for warfarin, magnesium, aluminum. Know why we mix our antacids, right? So aluminum causes constipation, magnesium causes diarrhea. If I mix them together, hopefully I have normal stool. Metoclopramide. So we have a black box warning for metoclopramide, which is EPS. So we want to make sure that we teach our patients if they experience any new tics or tremors or erratic movements that weren't there before, then they need to stop their med and call us immediately. Omeprazole. So long-term use with omeprazole, you are going to be looking at some risks for osteoporosis, especially since oftentimes we're using omeprazole in women who are 60 plus and they're already at risk for osteoporosis. Make sure you're getting them in for screening. H2 blockers. So we want to use a H2 blocker to reduce gastric acid secretion. So I want to take this because I want to have less heartburn. Sucralfate, so we use this in our patients who have stomatitis, who have ulcers related to gastric acid production, and we like to use it because it's a barrier drug, and this drug will go into your stomach, it'll coat it, it'll help keep the acid off of it. It's loaded full of sugar though, so watch your diabetics. Bismuth subsalicylate, so this is Pepto-Bismol. Pepto-Bismol is a salt and it's black, and I think the only reason it's pink is because that's the only thing they could get to cover up the black, because I don't think I'd feel as good about taking it if it was a black syrup of nastiness. Okay, so when it gets through your digestive tract and comes out the other side, it turns back into the black it's supposed to be. That's totally normal. If after a couple of days you are still having black stools and you have stopped taking the medication entirely, then we might need to worry about that being some sort of GI bleed, but at least initially, not a ton of concern about black stools there. Diphenoxylate, so this is a narcotic drug. We are using it to slow down your bowels. It's about time we used an opioid for its adverse effect. So we give you the diphenoxylate and that slows down your bowel and it stops the diarrhea. If I add atropine to it, it doesn't help slow down my bowels, okay? And I know that people think that because they're like, oh, this is an anticholinergic and it is going to depress the parasympathetic. But in this situation, there is not enough of the atropine in there to give you that type of anticholinergic effect. So what happens is when you decide that your diphenoxylate is super fun and you want to take it to get high, you get enough of that atropine in there to start having the adverse effects of the atropine, okay? So have an understanding of that. Zofran. So Zofran is going to block your serotonin receptors in your chemoreceptor trigger zone in your brain. Okay, so make sure you know your action there. Psyllium mucilloid, this is a laxative, it's a bulk laxative. And this stuff is powder and you mix it and it's gross. So big glass of water, mix, drink immediately, then follow it with another glass of water. Bisacodyl, so this drug is a laxative, it's a stimulant laxative, and We like to use this for your colonoscopy preps, okay? So when you're taking your colonoscopy preps, you expect to have some general discomfort, okay? So you're going to have some cramping, you're going to have the need to go to the bathroom a lot, and you should not use a laxative regularly. That's just weird. So we just need to make sure that our patients know that they need to not be eating with this, they need to not be drinking foods that can become solids, essentially. I don't know if you guys have ever seen somebody puke up milk, but it actually separates and becomes a solid in a liquid, okay? I don't need that in my bowel when I am trying to clean it out. Ferrous sulfate, so iron. Know how to take some iron, okay? So Z-Track your IM injections because it'll stain. Make sure you're taking it between meals because it just absorbs better. Make sure that you are drinking it with a straw and that you're rinsing your mouth out afterwards. If your patient is anemic, our goal before we add iron is to try to feed the problem. And this is dependent, right? If you are super anemic and you're struggling, it's not go home and eat. It's let's change your diet and let's fix it. But if you're just on your way down, let's try to feed the problem first. Let's talk about fixing it long term. So add meat, add red meat in particular to your diet. That will help increase your iron. I think a lot of people get prescribed diets that include organ meats. So make sure you don't let your iron get low or you might get that. So thiamine, know your food sources. Folic acid, who should get folic acid? Vitamin C, know your food sources. Potassium, know how to manage your potassium protocols, know normal levels. There's a lot of levels throughout this exam, so make sure you know what normal is, what's not normal for potassium, sodium, chloride, mag, glucose. That should just be a give me now, okay? TPN, we talked about TPN, and then your orlistat, so your weight loss drug, the one we watched that really awesome video on. Know what your adverse effects are for that particular drug. So the inability to fart with confidence, no wearing white pants, that kind of thing, okay? And that's it. So expect some sort of variation of that. We will have 2 more classes this week. Tomorrow's class starts at 10, and Friday's class starts at noon. We're having potlucks both days, so if you guys decide to come to an extra class, you're more than welcome. Bring something awesome to eat, and we'd be happy to have you. Okay, good luck, you guys.